Thank you for the great talk, and we are moving to the last talk of this session, and I'm happy to invite Professor Marieke Pijnenborg. She's a professor of clinical neuropsychology at the University of Groningen in the Netherlands. She specialized in psychotic disorders, studies extremely the effectiveness of different innovative psychosocial intervention on recovery processes using diverse methods such as virtual reality. She also studies identity as related to social media and different reflective processes, including insight, which will be the focus of her talk today. Thank you.
Thanks, Ilanit, for the very kind introduction, and also thanks, Ilanit and David, for having me here in Tel Aviv. I'm very excited to be part of this very inspiring lineup of talks that I've heard today. It's an honor to be part of it. And I'm also very aware that I'm the only thing standing in between you and lunch. So I hope you have some energy still left to bear with me during my talk. And I really liked your personal journey, and it was really brave to share, and I think it's really very inspiring. And I think as scientists we also make this kind of journeys, right? It is personal, but it's also the way we reflect on illness, on the interactions we have with the people with psychotic disorders. So your story has been really helpful, and maybe my talk mirrors a bit of that process, because it starts in a very biological way and then moves to a more personal and identity-focused approach. I've always been interested in identity. I think it started when I was a very young psychologist a couple of years ago. I was in a lecture room like all of you are, and a person would enter the lecture room, was in the hospital, and that person looked around and she said, "Hello, I'm a psychiatric patient." And I was really struck by that, because I felt, okay, if you step into a place where she was lost in the hospital, and the first thing you say about yourself is not your name or something else, but it's the fact that you are a patient. That to me was really, I was really impressed by that. And I think it was a start of a sort of a scientific interest, but also I'm also involved in treatment of people with psychosis. So it really guided me, and also my scientific interest. Just before I start, I wanted to thank the people who inspired my thinking in this regard, because important journeys in life you preferably don't do by yourself. Yes, and I'm from the Netherlands, so reflecting on identity and who you are, that's I think one of my social identities is being from Groningen in the Netherlands. One of my other important social identities is being a mother of 3 children in the age of identity formation. So I think I'm also an expert by experience in many ways, and observing how you come to a sense of identity. So having said that, today what brings us together is talking about medication, and I never liked the term adherence. I liked the term compliance less, because it's so top-down. But what we see is that many people don't take their medications as prescribed. It's over 40%, and that's associated with poor outcomes, as we all probably know. There's a lot of predictors of not taking your medication as prescribed. So substance abuse, cognitive impairments, lower levels of education. Now you can read the rest of the predictors on the slide, but the 2 themes I will focus on today are insight and self-stigma. So insight and self-stigma are both associated with lower medication adherence. And like by disclaimer, before I started, you can define insight in a very medical or biological way as sort of the outcome also of a reflective process. And that's, I guess, what is often done in the literature. So insight can be seen as a 3-dimensional concept, clinical insight. First of all, it's about not agreeing with the label. So in terms of psychotic disorder, saying, okay, I don't have a psychotic disorder, I don't identify with that label. Second, it's about not recognizing the symptoms of that illness. And the third is not recognizing a need for treatment. And these are different dimensions that can fluctuate independently of one another. So people can say, I do agree with the label that I have a psychotic disorder, but yet I don't need medication or I don't have any symptoms at this moment. So they're independently of one another. And of course, it is an important question how poor insight has its onset. So that was a thing that Lisette and I and many other people have been talking about a lot. And what we see in literature is that many reflective, self-related processes have been related to insight. So ability to reflect on yourself has an association with insight. And also, like Lisette already mentioned, theory of mind. So the ability to put on the mental shoes of other people and to look at yourself from the perspectives of others, that helps to shape our sense of who we are. So it's not only reflecting about ourselves, but also taking into account information that other people provide us on who we are. So during our studies, we used neuropsychological tests, we used neuroimaging, and we came to the idea that indeed there are some reflection about others processes that are core to our sense of insight. So what we did is we performed a meta-analysis with a lot of people. Lisette was involved, Ilanit was involved, and we summarized all literature on neuroimaging and insight. So because we thought if insight is indeed sort of a reflective process or a biological process, it should have its correlates in the brain, right? Because when I started as a psychologist, I was taught that insight is a biological given, it is a symptom, and there's nothing we can do about it. So from this biological perspective, you would expect that there are neural correlates of insight to be found in the brain. So we summarized all literature on structural and functional imaging studies on insight in psychotic disorders. And we did a systematic review, and we found that for structural studies, we found that there was less volume in widespread brain areas, in particular the frontal areas of the brain. Oh, this is really unsharp. That's a sad thing, so you have to believe what I'm saying, and so for today I think that I'm quite reliable, so my perspective, you should trust me on this one. The green is overall insight in structural studies, and interesting also for today is that the pink one, that represents the dimension of insight that is the need for treatments. So that is a bit like Lisette said, it's also sometimes quite hard to interpret these imaging results, right? Because it would be quite strange to say that there's something like a need for medication blob in the brain or something like that. But what we do now is that these areas are parietal in the parietal lobe, and that they correspond, for example, with theory of mind processes. So it may be that being able to take the perspective of others and agreeing with your doctor saying that it's maybe better for you to take medication, that's why we found these correlations. But it's all correlations are quite low. So thank you. Cool. Just okay, thank you for that. I put on my high heels, so that's why I'm a bit longer than normal, maybe. But all correlations were quite low, and also it does not really explain why insight fluctuate over time. If brain structures, they are like not expected to fluctuate over time, but so that's why we thought other processes should play a role as well. It's not only a brain story, of course. And in functional studies, in activation studies, for example, using the paradigm that Lisette already presented on self-reflection, we found that activation in especially the frontal areas during tasks that are about self-reflection, about theory of mind-like, and about, for example, error monitoring, so being able to detect errors and being able to flexibly correct your own performance, that activation in these areas or during these tasks in frontal areas were associated with insight. But that's not the whole story. Like I said, all the correlations were quite low, and we also found that it's not only a biological story. There's a lot of stigma, as already mentioned today. Tomorrow I will talk about social media and identity. And what you still find on the internet, on social media, is that schizophrenia is among the most highly stigmatized disorders of all. So if people go on the internet, if people have met their psychiatrist or psychologist and are labeled with a psychotic disorder and are reflecting on that and are thinking, do I recognize myself in that, and they go on the internet, that's where most young people find their information these days. They find this highly stigmatized information. Still, they find information on killers. If you look at the hashtag on Twitter that's used the most often in relation to schizophrenia, it is school shootings. So that's not a pleasant image, and they find like images of young people wearing hoodies, sitting somewhere in the street. So that's not something I often see my patients doing, but it's the image that is like in the social media. So these kind of stories and this kind of information, they really make people to reflect and to say, I'm not going to apply this label on myself, right? And people who do, they experience self-stigma because they are already often quite familiar with all kind of prejudice on mental illness. And then if you apply it to yourself, this is a classical one, I think familiar to many of you, but it is the modified labeling theory by Link, which was originally, I think, from Goffman. But it is, if you have a label of a mental illness and you apply that label to yourself, you start losing hope, but also stop undertaking actions that get you somewhere. So people don't apply for jobs anymore. People don't go on dating apps anymore because they think, what can I expect as a person with a psychotic disorder? Who wants to date me? Who wants to be my partner? Who wants to hire me? So because of that self-stigma, people give up trying. So they the stigma in itself becomes a predictor of poor outcomes. So it becomes a sort of self-fulfilling prophecy. So that's what we integrated years ago on a model of poor insight. That insight is predicted by non-social cognition, so by flexibility that I talked about. It's predicted by this theory of mind-related processes, and it's predicted by the sensitivity that you have for the stigma that's related to psychotic illnesses. And together, these factors predict the ability to reflect on yourself. And the outcome of that self-reflective process is what we would call clinical insight. So adherence or accepting the label, recognizing symptoms and recognizing need for treatment should be predicted by self-reflection. So having said that, we've been thinking a lot on how we can use this knowledge to improve the outcomes for our patients, to think about treatments. And we thought if we could improve that reflective process, then we can also improve outcome. But on the other hand, insight can also be predictive of sadness, right? If people have, I had a patient and we've been doing a lot of psychotherapy, and after like 4 or 5 years, he said, okay, Marieke, I think that maybe I was wrong. But if I was wrong, I lost 5 years of my life. pursuing things that were not even real, that did not exist, and that makes me so sad. So I think it's really understandable that people can be really depressed if they have more insight, and especially when they tend to stigmatize themselves. Because if you say, okay, this is about me, you can also see yourself as a person with less opportunities and less hope. So if you have interventions that focus on increasing insight, then you should also take self-stigma into account. And that's what we did. I guess I just skip, with an eye on the time, I just go to this one. We did an intervention that we called Reflex. And in Reflex, we had 3 modules of group training in which we talked about self-stigma. And in that we challenged all stigmatizing beliefs on schizophrenia. Then we talked about who am I? So we had people talk about their own narrative, and to have people also, we also asked them to ask for the perspective of relevant others, to increase that, like I said, that theory of mind aspect. So we asked people, okay, go home and talk to your friends or talk to your mother and ask them how they see you as a person, not as a patient. What are the roles? How are you relevant to them? What's your story? And then finally, in the last module of 3s, we had a diary study in which we had people monitor their behavior during the day, and they had to fill out questions. What are you thinking? How are you doing? So we stimulated self-reflection during daily life. So, and after that treatment, people had to make a big poster, and it was their Who Am I poster, and all the information that they collected during training about self-stigma, about how other people perceive them, and about their reflection during daily life was filled out as a big poster. And we did a big randomized control trial and compared that intervention to cognitive remediation training. And what we did find is that insight, both perceived by the patient and perceived by the clinician, both led to a reduction of self-stigma and to an increase of insight. But strangely, that also happened in the control condition. So there was no specific effect. Both groups improved on insight. So it's hard to tell what happened there because it was not in first episode patients. These were all patients who have been ill for quite a while. So that was a bit of a strange finding. But what people did like was having the opportunity to exchange and to build on a personal narrative together with others and other people in their own environment. So, and I also did an overview of other effective treatments for insight. And we see that cognitive behavioral therapy can have an effect on insight. So people can develop more insights by CBT. We looked at the effect of transcranial magnetic stimulation, which also has been linked to better insight. So I don't know if you're familiar with that technique, but that's like a magnetic stimulation of relevant parts of the brain. So magnetic stimulation of the frontal areas has been associated with better insight. Really, a sort of stimulation of reflective processes. And also together, Paul Lysaker, he developed the MERIT, the intervention that stimulates self-reflection and other reflection, and that was also associated with better insight. So what we have seen is that we can increase insight in patients, but that stigma still plays a big role, self-stigma. And that self-stigma is also associated with poor adjustment, but also with less medication use. So a relevant question is, what would happen if we do change the label, right? Because in psychiatry, I think Magnus already addressed it, we tend to label people and instead of sometimes listening to their personal narrative. And by this label, we induce a lot of self-stigma. So over the years, for example, in the Netherlands, there's been a big movement saying that it's called schizophrenia doesn't exist. So there was a big pressure on changing the label of schizophrenia to reduce all the prejudice and stigma. In the Netherlands, we didn't really do that because it was like under a lot of debates, and the consensus is still that we do use the DSM labels, even though in clinical practice, myself, I hardly ever use the label because I'm interested in persons' stories, their personal narrative, and their own framework, how they explain what is happening to them. But in the Netherlands, we do still have to use these labels, for example, for mental health care insurance. So we could not get them off the table altogether. But in other countries, they experimented with different names of schizophrenia to change the stigma. For example, in Japan, they called it mind split disease, or they changed it to integration disorder. So it's a disorder of integrating information. And that led to less negative reports in the media and less perceived danger. So in Japan, changing the label was successful in reducing the negative opinions in the media about people with schizophrenia. In South Korea is Dutch, but it's South, trust me on that one again, they called it attunement disorder. And that was a term that was found to be too difficult for the general audience. So if you want to change the label, you should think of a label that is understandable to people and that people can really use. What we also know, as a side note, from previous research on stigma, a lot of research has been done on stigma reduction also by using a more biological-oriented approach. So telling people that schizophrenia is like a disbalance of the brain and things like that. But what we know from research and from personal experience, that kind of approach does not help to reduce stigma. It only increases stigma because it sets people apart from other people. People think, okay, these people are biologically different from myself. It strengthens the us-them kind of thinking. So the only thing that really helps against stigma is contact. Talking to people, meeting people, that's the only thing that we know from a lot of studies that really helps. Okay, back to the slides. In Japan, the people found that if you use the term disordered thought and perception instead of schizophrenia, it did not lead to differences in the media. So, to summarize, I think that a lot of people with psychotic disorders have different appraisals and reasons not to take medication. We've seen that poor insights can be a reason not to take medication, and self-stigma is also associated with not taking medication. And I think we've seen a lot of stories this morning telling us why that would be the case, right? If you feel very bad about yourself because of a label, medication is a constant reminder of that label and that you are a person with mental illness and that you have to take care of yourself with medication. So it triggers a lot of negative, self-stigmatizing thoughts. So, and what we also have seen is that insight is not only a biological thing. There are brain areas associated with insight, but these areas are most importantly related to self-reflection and theory of mind, so self and other reflection, and that stigma so plays a big role in insight. So if we want to take something home about how we communicate with people on medication, on a shared reality, it's so important to understand the personal narrative. I think, we've come across many examples of why labeling is really, we should not label. And so it's much more important to ask a person, what has happened to you? How can I help you? Then how can I label you? And which label suits you? So it's about the personal story, the personal narrative of which medication use is a part. And so it should be integrated in a larger story on identity, on who are you as a person, what are your needs, And in that process of shared decision making, of working together, I think we should always respect people's autonomy. They are the agents in their own stories, and therefore focus on resilience and always keep an open dialogue with one another. So thank you very much for your attention.
Thank you so much, Marieke. And we have time for one or two questions, please.
What are the factors to take in deciding what is it poor insight or beneficial insight?
Sorry,
what are the factors that you take in order to decide what is a poor insight or better insight for a
you mean how do you assess insights?
Yeah,
I think there.
Better and what's like.
I think there are several questionnaires that, but they are from a they use the medical model. So according to these questionnaires, you have good insight that when you agree with the label and when you recognize your symptoms. For example, if you hear voices, you attribute these voices to that label and see that you need medication for that symptom. So we do have several instruments that assess insight, but most often in a very traditional way. So you can also, of course, look at how a person, I think it's more important to look at the person's narrative and their personal story. So there are also interviews that assess the personal story, but in a traditional way, we use these questionnaires and interviews that, that assess insight in line with the thinking of the medical model. Does that answer your question, or I'm not quite sure? Yeah.
It's a bit philosophical question also.
Yeah, but I think that's very important, because if you say I'm the one who is going to assess whether you have insight or not, that's really top down, right?
Yeah,
so it has.
It feels to me like we also labeling
what's reality.
What is poor insight and what is like good insight, and I think it's a very difficult question.
I think it's really a very complicated question, and I think there is some sense of shared reality, but also, for example, in times of the pandemic, we've seen that there are so many realities, and that is not upon us to judge or to say this is the correct reality, because there can be many. So it is indeed really hard and really a bit arrogant to say this is the ultimate reality and you don't see it. Yeah, that's, I guess, a line of thinking that many people have, but I don't agree with that. So that's indeed a philosophical aspect to this topic. Thank you. Yeah.
Last question.
Okay. You brought it back to the pandemic, which is an issue I'm very attached to. Just yesterday I saw this.
Quite controversial, but we did write an article about pandemic and conspiracy thinking and insight and things like that. So it's really, but I think the most important thought on that I have is, it's not about having the same reality. It's about looking at what you share instead of what sets you apart. So I think if we have learned anything from the pandemic, is that we should respect other people's thinking, and that we try to keep on trying to connect. If we are a clinician and a patient, or just family members or friends or colleagues or whatever, I think focus on the things that unite us and that we share. I think that's the most important. The relationships between people are more important than having a shared reality, in my view. So, yeah.
Thank you very much.